All right. All right, so we have no disclosures to make. And the objectives for this afternoon are kind of to really kind of use case presentations, as we've seen already today, to kind of demonstrate the importance and the utility of critical thinking in the clinical laboratory. We're also going to talk about how clinical laboratory tests are classified in terms of complexity, illustrate why these molecular tests work as well as they do, and then demonstrate some of the challenges that are associated with routinely using these tests. So the first question, audience participation, would be, do you perform nucleic acid amplification tests in your laboratory? Okay, that looks good. All right, virtually everybody does now. So this will all kind of have a relevance to what you're doing today. So the name of this, critical thinking in the age of the microwave was something that, as the technical advisory group was meeting, that came from this quote here by a Dr. Michael Mina. He's an ID physician on the East Coast, and this quote was, we were into probably getting close to a year into the pandemic. There were a lot of molecular tests coming on the market and everything that were available for SARS-CoV-2 testing. And so then somewhere I saw this quote from Dr. Mina: most microbiology lab testing is like a microwave dinner, says Mina. It comes as one kit. You push a button and you get your result, and nobody can screw it up. And then he continued on about the CDC test kit for COVID-19 is more like Blue Apron. Comes with a box of ingredients that you go to any store and buy, but it's nicely packaged for you and comes with a recipe. And I don't know how you took this comment, but I was pretty offended by this comment. And if you remember this COVID-19 kit from the CDC, the initial versions that came out, one of the reagents was contaminated with some target in it. So, you could get some results where the controls look good and everything, but you were getting incorrect results. So, I kind of thought about this. Yeah, you put it in there and you push a button. And so this was really got me thinking, there's a lot more to all this than what's in this quote. So first I'm going to start with a little case a couple years ago, 2018. So for about a 2-week period here, December 12th to 28th, 2018, Hospital Lab X detected influenza B from 5 patient specimens using an FDA-cleared waived molecular test. Now, at this time in Wisconsin, there were only a few scattered cases of influenza had been reported by the State Lab of Hygiene, and very, very rare cases of influenza B being reported at this time. So here we've got 5 in this period. And so you might ask, well, how would you know, what else is going on at this time? So something that is available from the Wisconsin Department of Health Services is their, I think it comes out weekly, is their respiratory virus report. So this one here, the last 2 here are the 2 weeks just prior to the 2-week period where this laboratory was having these influenza B positive samples. So the week before, there were 3 flu Bs, and then the week before that, there was just 1 flu B. So say we were lagging a week, this certainly would be available for this week to people during the week of 12th through the 28th or whatever it was. That here we've got 1266 with just 1 flu B. So this was something that would be available to people. So you'd have an idea of, how much respiratory virus activity is going on. Let's see. So now,
get your cursor manually back on the screen, see if it's off, and just like put somewhere on the screen.
yeah, all right, so during this same time period, the 12th through the 28th, this laboratory had tested a total of 69 specimens. And so in addition to these 5 that were positive for flu B, they had 13 that were positive for RSV and 1 that was positive for flu A. Oh, I think it did turn off maybe. Yep, it did turn off. There we go. Now for the region between the 12th and the 28th in this same health system, there were a total of 206 specimens tested. Of those, 2 were reported positive for influenza A, 33 were positive for RSV, and 0 were positive for flu B. So, there's something going on here with 5 positive flu Bs in just this 2-week period. And so this is that same report, and the last 2 columns cover the 2 weeks from December 12th to December 28th. And so there's roughly 3,400 specimens tested in Wisconsin during those 2 weeks. And what do we have? 13 that were positive for flu B. But here we have 1 laboratory that has 5 positive for flu B in just that 2-week period. So a little different than what is being seen around the state. So the laboratory, does the right thing. They have a positive early in the season, and they're sending those samples to the State Lab of Hygiene for confirmatory testing. And these are the results they found from those 5. There's specimen 1, specimen 2, specimen 3, specimen 4, and specimen 5. So, none of them were confirmed as being positive for influenza B. So, what happened here? They're using a wave complexity test, 1 reaction tube per 1 instrument. All the tube controls passed. All the instrument, they use the Roche-Liat controls passed, yet they don't appear to be getting the appropriate result. But Dr. Mina says, most microbiology testing is like a microwave dinner. Comes with 1 kit, you push a button, you get your result. Nobody can screw it up. So, what is going on here? So I think I will turn it over to Heather now for her part.
Thanks. All right, so this will be our next question. Do you receive and review in a timely fashion the regularly disseminated respiratory virus surveillance report from the Wisconsin Department of Health Services, Division of Public Health, and the laboratory surveillance report from the Wisconsin State Lab of Hygiene? Oh. There we go. All right, looks like we're pretty consistent, A, B, and C. So yes, I get them. I review most of them right away. And on occasion, I review them away, but not very often. There are at least 6 of you who do not receive those reports. They're super helpful. And if you find Aaron when we're done, get yourself signed up, because they'll help in a situation like this for sure. All right, so we are going to move into how lab tests are classified. So it's kind of a busy slide. So over there on the left, it says tests that are waived under the 42 CFR. Their criteria there are they're cleared by FDA for home use. They employ methodologies that are so simple and accurate as to render the likelihood of erroneous results negligible, or they pose no reasonable risk of harm to the patient if the test is incorrect. For all other tests, which is what's on the right side, using that list of 1 through 7 criteria and giving a score of 1, 2, or 3 for each one is how they determine whether it's moderately complex or highly complex. So that's the knowledge, training experience, reagents and materials that need to be prepared, operational steps, QC, calibration, troubleshooting, and then how much interpretation and judgment is needed. So if the score comes out 12 or less, it's a moderate complexity. Greater than 12, you get a high complexity test. All right, so CLIA wave test. Some of those would be your urine pregnancy tests, your rapid streps, that influenza that we just saw. Moderate complex, so that would typically be found in your instrumentation. Most of you are familiar with these types of things, your chemistries, your hematologies, things like that. High complexity things would be some of your mass spec, cytology. There's a whole list of things that are high complexity tests. So here's just a snapshot of some of our waived nucleic acid amplification test systems. So we have the Mesa Biotech up there, there's the Roche Liat, we have the Abbott ID Now, and then the Gene Expert Express. All right, so we're back to that, how are lab tests classified? Waived complexity does not mean fail-safe. And now we have the CAP checklist for our molecular-based microbiology testing waived tests. Ray shared these on here. I will kind of read through them. So I will say I am not a CAP lab, I'm a Joint Commission lab. And Joint Commission standards for wave tests is way shorter than the CAP. I mean, Joint Commission is like ABC, do you run controls as indicated? Do you do some type of yearly competency? Like you're pretty much good to go. So CAP does a little bit better job. So we have the laboratory monitors for the presence of false positive results. This is something Joint Commission does not require on a waived test, but they don't have a section for waived molecular. The final report includes a summary of the test method and information regarding clinical interpretation. The laboratory monitors for the presence of false positives. So if we look down there at the bottom line, evidence of compliance, you can prove that by recording that you reviewed the data, doing wipe testing, which we talked about a little bit earlier, reviewing some of that statistical data, doing evaluation and corrective action if needed. Specimen handling. The laboratory uses appropriate processes to prevent specimen loss, alteration, or contamination. We already talked about the final report. I'm going to turn it back over to Ray.
Okay. Thank you, Heather.
Yeah.
So when that laboratory that had the 5 samples that were positive for influenza B, back then in 2018, it was very easy to look at the amplification curves and the crossing threshold for the tests that you were running. And so this is what the 5 flu B positives looked like in terms of an amplification curve. It's the red line here. So a very, very small amplification curve with a very, very late crossing threshold. So it was 42, 41, 40 cycles before those specimens flagged as positive. So this, suggests a very weak signal, a very small amount of target nucleic acid, influenza B RNA, being detected in those patient samples. And the thing about these nucleic acid amplification tests is that they're very powerful in terms of their ability to amplify target DNA and make it more readily detectable. So this is just an example starting with your template DNA, and then if you should get amplification starting on that very first cycle, that there's enough target in there that one target copy gives you 2 amplification products, 2 gets you 4, 4 gets you 8, 8 gets you 16, and then by the time you get up to 35 or 40 cycles, you've got billions of copies of your target region to detect. So it's certainly much easier to detect this horizon of amplified product than it is to detect that original target in your sample. So when you have a very small amount of target, the horizon is right here. But again, the assay, that's still enough to signal positive in these assays. So a very, very tiny amount of target nucleic acid that gets in that amplification tube can give you a positive result. And kind of another way to look at how much product you can get in these amplification reactions, if you look at the Earth is almost 200 million square miles. So if you put a square mile grid over the Earth, you'd have about 200 million squares over the Earth. If you had a 100% efficient PCR reaction that went 40 cycles and started amplifying at cycle 1, you'd have enough DNA at the end, amplified product, to put 5,000 amplicons into each one of those square mile grids on the Earth. Each one of those 200 million squares would have 5,000 copies of the amplified product. So that's a lot of DNA, that's a lot of amplification power. And so these molecular tests really, pushed aside like antigen testing and everything, because the big advantage was for them is these less than optimally collected patient specimens or ones with low amount of target that would never be positive in an antigen test would be positive in these nucleic acid amplification based tests. So you would be able to pick all those up that you never could before using antigen testing. So here's a laboratory. This is one of the areas of our laboratory. It's kind of like a lot of laboratories. It's just packed everywhere with equipment, every spot covered with something. Got a biosafety hood there to, to manipulate patient samples. Gene expert here. And something to think about is you're running all these tests, and how much of target nucleic acid is going through your laboratory. So here's RSV and influenza in our laboratory from starting in September of 2022 and going into the end of February. And here in October, half the specimens that we tested for RSV were positive in October. We were testing, at that peak time, we were testing about 1,000 specimens a week for RSV. So there's 500 specimens a week going through this laboratory, going into that cabinet, being set up that are positive for RSV. Influenza peaked later in December, about 45%. At our peak time for flu testing, we were testing 1,700 specimens a week for influenza. So we've probably got, again, 500 or 600 specimens a week with influenza A nucleic acid going through our laboratory. So that's a lot of specimens being opened and closed, manipulated and everything. Some potential for target nucleic acids to get around our laboratory. So, and this is just an example, one that I always love this figure here. This is a gel of a nucleic acid amplification test was done by BD. They were developing an assay for M. tuberculosis and M. bovis. And they had a couple of primer pairs that would make a 56 mer target and a 35 mer target. And they were showing, 10,000 copies on down, how sensitive these nucleic acid amplification primers were. But what's interesting, if you look at the ones with 0 target in there, they're positive as well. So as they've been developing this assay, working with this assay in their laboratory, they've contaminated their laboratory with target DNA and were picking it up when they were doing this assay. But this is in one of the biggest journals out there. This is published in the Proceedings of the National Academy of Sciences. But they spun this perfectly. They said, but our assay is so sensitive that if we even contaminate our environment with tiny amounts of target, our assay will pick it up. So, here it was something to show the performance of their assay. But again, it illustrates the issue when you're working with a lot of specimens, or in this case, this type of DNA, it can get around your laboratory and you won't even realize it. So concern for contamination that could be in the environment and get in your amplification reactions. So where does that come from? Many sources. Amplified product, a possibility. Proficiency samples are a big worry of mine because they frequently come with a lot of target nucleic acid in them, and they are smoking hot. Patient samples, as I've just been illustrating, you've got a lot of positive specimens coming through during peak times. That's a lot of nucleic acid going through your laboratory. Things get contaminated, pipettes, hood decks, things like that can contaminate, get on a glove, clothes, hair, find its way into your amplification reaction mixture. And that's probably what we have going on here. The red line didn't go along this time, but with this weak positive, and it really suggests that we're having an issue somewhere with some contamination in the environment that was getting into these amplification tubes. So how do you know you might have contamination and an issue going on? If you run negative controls, those could be positive. That would be like in that Proceedings of National Academy paper would be a sign. In our case here, we had an unexpected number of positives. We had 5 positives in 2 weeks, where they only had 13 out of 3,400 in that same 2-week period around the state. High CT values, like we have right here, in our case here, a real good clue. Wipe testing can be very helpful. We didn't have that here. And confirmatory testing was negative. That certainly we had here, suggesting we have a contamination issue. But you may not know. If it occurs so sporadically and seldom, you may never pick it up. Now we'll go back to Heather for another case presentation.
All right, so we're going to look at a case study. So this was a 65-year-old oncology patient, came straight to admission for dehydration and possible septicemia. He's had septicemia before, has a high white count. Collected blood cultures on admission. 13 hours later, first set shows up positive with a gram-negative rod. So we set the gram-negative blood culture bottle up onto our Verigene system for gram-negative ID panel. So results are there on the right. Klebsiella oxytoca is detected. So we did sub that bottle to media so we could set it up on the Vitek for susceptibility testing. So this is the next day. And here's our Vitek printout. And amazingly, I shared the same organism on a Vitek printout that Tim did, coincidentally. So Vitek ID gave us a 99% probability of Rallotella planticola. So this was a Saturday morning, and my staff called to say, which one is wrong? So go back to the Verigene a little bit. I don't know, there's a ton of people who run a Verigene system. So you can see up there on the left, the Verigene is two parts. There is a tower where it actually does the processing of the sample. And then that little smaller piece on the right is essentially a reader that takes a picture with a camera. So I don't have a pointer. You can see all the supplies and parts down there in the bottom left. There are 4 components that make up the test. There's an extraction tray, there's the tip assembly, there's your utility tray, and then your actual test cartridge, which is actually a glass slide. So it is a moderately complex test. Sample to answer, and down here on the bottom right is what the analyzer essentially looks at when it takes a picture of that slide at the end. So it's adding silver and gold particles that will help shine up when it takes a picture. So I asked my staff to go back into the operator's manual for the Verigene and look at cross-reactivity. The Verigene does actually have quite a few things listed of what can cross-react with some of its markers. And so highlighted up there on the top, it says Rallotella planticola will cause a false positive K oxytoca detected result on the Verigene system. And so the staff ended up adding a comment to that blood culture panel, which we had already reported out as a K oxytoca, to state this exact verbiage, that Rallotella can cause a false positive. Kind of helps to tell the provider we didn't mess up the day before, we didn't report the wrong thing, it just they can cross-react so that we can kind of tie those pieces together. But both tests were performed exactly as intended. Nothing was done wrong on either one, they just get different answers. One more case study.
Okay. So we're going to close with kind of a scenario of a couple of cases we had that I'm still critically thinking on and trying to figure out what was going on here. So we had a 53-year-old male who presents to the emergency room twice. 54-year-old went to the ED with altered mental status, some left-sided facial pain, and some facial tingling. He was admitted to that hospital, had extensive testing done, but nothing was found, so he was discharged home. However, he got back home, and his children felt that he was still out of it. So the next day, he went to a different emergency room for evaluation. And there he had a lumbar puncture performed, and it really didn't show a lot. Clear and colorless, a couple of nucleated cells, a couple of RBCs, nothing remarkable about the glucose. Protein, a little elevated, maybe 40, 45 being, and below being normal. It was 102. So he was in our hospital. He had a CSF cytospin gram stain, no PMNs, no organisms seen. And we ran our meningitis encephalitis panel, and it was positive for human herpes virus 6. Now, we had been running the ME panel for about 18 months when this case came up. We probably had 70 specimens tested in that time. And we had never had a positive human herpes virus 6 until we had this one right here. The individual had a brain scan which showed some abnormalities, some foci in certain areas, but not specific for any particular condition. And so he was admitted because of the facial and upper extremity tingling and confusion with a diagnosis of viral meningitis. He resolved with over the next 48 hours, and then he went home. And so then he was followed up by neurology. They took that spinal fluid that we tested for human herpes virus 6 and did an HHV6 viral load on it. And it was about almost 1,500 copies per mil of HHV6 DNA. They also did a viral load on his serum from that time, and it pinned the curve. It was greater than 999,000 copies per mil. So human herpes virus 6, as Dr. Munson mentioned, can be challenging to interpret, and some wonder, why it's a part of the ME panel in the first place. HHV6 causes roseola, and 90% of the population have probably been exposed to this virus by the time they're 3 or 4 years old. Occurs very early in life, and like all herpes viruses are forever. Can go latent in certain nerve tissues, and reactivation can cause encephalitis, maybe similar to the picture that we've seen here. You can have some HHV6 viral DNA integration into host DNA showing up, causing a positive, but they don't believe this occurs very often. So here we went 17, 18 months without a HHV6 till this one came in, this patient came in. So our next ME panel was a week later, 5 days later. We hadn't run one since the previous case that I talked about. Here we had a 13-year-old who's in one of our affiliates, an outside emergency department, severe headache for several days, fever. Lumbar puncture was performed at that hospital's ED. Not very remarkable. Glucose and protein looked pretty normal. CSF gram stain, no organism seen. So they sent a couple of tubes of CSF to our laboratory for further testing. So we ran our ME panel, which they requested, and it was positive for human herpes virus 6. So we hadn't ever seen one, and then we see our second one within 5 days of seeing our first one. So this, raised all kinds of warning flags, because, our techs, have a kind of a script they have to go through before they report out the ME panel for many of the reasons that Dr. Munson mentioned. Concerns about positive predictive value and prevalence of all these being so low. So certainly this 13-year-old had symptoms that could be associated with a meningitis. We repeated the ME panel on a different tube of CSF from that individual, and that was positive as well for human herpes virus 6. There was no neurology follow-up in this case, looking at HHV6 viral loads. So, we reported this out. The physicians felt that this was probably a false positive. We did some some wipe testing, around the area and didn't find anything. So this one's still kind of a head scratcher to me. When we do our ME panels, we do take a lot of precautions with this. Again, because this is such a sensitive test, and we have all kinds of DNA that's on this panel going through our laboratory. We do herpes virus assays, E. coli, group B strep is on here, strep pneumoniae is on here. We have all that going through our laboratory all the time. So what the manufacturer recommends is to process all specimens in a biological safety cabinet when you're doing this testing to guard against contamination of the specimen or the test pouch with target DNA, and to guard against something from the operator perhaps getting in there. So we have a number of biosafety cabinets, but we don't have a dedicated one like they would like. So what we've done is we've set up a dead air box, nucleic acid dead air box on a counter, and all that's done in that dead air box is this meningitis encephalitis panel. And then we also have the tech that's setting up the ME panel has to wear a new laboratory coat every time. And back before the pandemic, they had to put a mask on also when they ran this assay. And now they do, because we just in the last month have gone maskless at St. Mary's. So they have to wear a mask as well when they set this up. And then we have routine wipe testing for the meningitis encephalitis panel. And we check inside the hood and around it for target nucleic acid. And then we also process one specimen and one pouch at a time in that hood. So we really, go to some pretty good lengths, to ensure the integrity of this assay. So that's why it's kind of so puzzling, with that second human herpes virus 6, 5 days after the first one we had, and when we hadn't seen one for a year and a half. So it was just kind of a conundrum about, what was going on with that 13-year-old. Now, when we get a positive result on our ME panel, the techs have a script to follow, as I had mentioned, to correlate those ME panel findings with every other laboratory data. Do they have signs and symptoms of encephalitis or a meningitis? If things don't match up as well as we would like, then we repeat the test. We try to use a different aliquot of CSF for the repeat testing, but we aren't always able to. And I will say, when we were verifying the ME panel, we did have 2 false positives when we were doing that verification. One was for E. coli, and really didn't know where that came from. The other one was for Cryptococcus neoformans. And at that time, we happened to be also verifying a Cryptococcus neoformans antigen test. And we were growing up some Cryptococcus neoformans, so we could spike some simulated samples and things. And so there, we think it kind of came from when we were manipulating the Cryptococcus and having cultures of it. So the final question for the audience is, if I get an erroneous result for my nucleic acid amplification test, it is always the test reagent or the instrument's false if I don't get the right result. True or false? So 100% false, because these These assays are so sensitive, and it's very important, to really understand all the unique facets about them to help interpret these results. So these are just kind of some points that Heather and I would kind of like you to go home with, is how important critical thinking skills are for even the most simple laboratory tests. You could get a specimen mix-up, incorrect labeling, timely review of respiratory virus reports from public health can help you determine validity of certain nucleic acid amplification tests for respiratory viruses. A working knowledge of the instructions for use maybe will help resolve discrepancies. Nucleic acid amplifications are very sensitive and require special care to ensure the accuracy of the tests. And just because a test is waived complexity doesn't mean it's foolproof. And I don't believe that microbiology testing is like preparing a microwave dinner. So we'll stop there, and happy to take any questions or comments. Thank you.
All right, who wants to comment about this testing? All right, we've got somebody starting. Good.
Ask Ray.
I'll ask both of you. Am I on? Yeah. Excellent job, both of you. I have a question regarding the WAVE PCR testing with respect to wipe testing. Do you have any recommendations for how wipe testing can be done in these small confined areas with these small confined boxes versus some of these larger analyzers, which we may already be doing wipe testing on? So where to wipe, how frequently, and so forth.
I'll start on this one. I was never a big advocate of wipe testing, and as you can see, I'm old, and we were titrating the magnesium when I started doing PCR and everything, and when I was a postdoc, one of the other postdocs cloned something right off the bench in the laboratory. But, I thought, a lot of these, should be so well engineered that, this really shouldn't be an issue. But I came to realize that isn't always the case. And so, I do some routine wipe testing now that I thought I would never be doing. But for Dr. Munson's question, those small instruments, just the contact areas, where you're pushing some icons on the front and things like that, would wipe test those, the counter around them. Also, perhaps we've had some good luck finding nucleic acid on the box where the reagents are stored, like on the lid of the box or something. We didn't find that like for the LIAT, but for our reagents for the BioFire instrument, we found some target nucleic acid on the box. So those would be kind of the places. How often do you wipe test? I vary. Some things I do every week, like chlamydia and GC testing. You had, someone was up here discussing, Lab Jane, I think that was one of your cases, Eric, on the chlamydia and GC, and they had 20% positive and everything. I think chlamydia and GC is the test that I most worry about, because you get one of those wrong, and you come back 5 days later and say, never mind, they may already be divorced, So, that one worries me the most. So that one I do every week. The ME panel stuff, I do that once a month. A lot of other tests, I don't do any wipe testing at all yet, unless I have concerns. Do you have anything to add, Heather?
Not to wipe testing, but one of the things I've done before, so For example, working in chemistry, and I had the same tech set up 2 COVID flu RSV tests in a row, back to back, set up by the same tech. Both came up positive back to back for COVID. And it was a time period where we weren't seeing, as many COVIDs as we were for a while. Supposed to be set up in a biosafety cabinet. That's our policy. She did not set them up in the biosafety cabinet. She set them up on the countertop. And so I had a different person reset them up in a biosafety cabinet, clean everything first. The samples both legitimately did end up being positive, but while it wasn't a wipe test, we've done that before, have somebody else do it in a different location just to make sure we don't have those environmental factors in the mix.
Yeah, thanks, Ray and Heather. Question about the amplification curve on that flu A, flu B. I was having trouble reading it. If I understood correctly, there was a very nice, strong curve. That was the internal control of the IC.
Yep.
And then there was this little thing at the bottom. That was the flu B?
The red, yeah. The
Really?
instrument was calling that positive.
Really?
Yep.
I mean, to me, that looked so fake.
Yep.
I mean, there was no logarithmic
And now,
curve to it.
Roche's. Well, when you have a really low amount of target, you don't see the classic sigmoidal curve. But Roche has now taken away the ability to see the amplification curve and made it hard to find the crossing thresholds. But that was what it was calling positive.
Yeah,
And-
I mean, from my eye, I agree.
Yeah.
It was because, you would have had to expand that scale low down to see if there was a true curve there, but it
Yeah.
sure looked pretty linear.
It sure did, didn't it? Yep.
Okay, I just want to make sure I was...
So just to comment on the curve, to Dr. Nowicki's point too, we run both Cepheid and BioFire, and we've seen, not this past year, but year prior, where we've run a 4-plex on the Cepheid, and you'll have negative flu, negative COVID, negative RSV, and the provider asks, all right, now run the full respiratory panel. You run the full respiratory panel, and we had seen a couple cases in a couple weeks' time where everything negative on Cepheid and influenza B positive on respiratory panel. And we would go back and look at the Cepheid MELD curves, and you could see right at the very end, right around that 39, 40 cycle, a slight pickup in that influenza B instrument calling it negative, which was interesting for us, I think, from a learning perspective too, seeing discrepancies between 2 of those molecular panels when they're both testing for the same thing. You have a, not quite a detectable takeoff on the Cepheid, and I don't know if it's just a probe and primer set, more sensitive on the other instrument in that case. So that was just a commentary related to that. My question for wipe testing, are you guys doing wipe testing right before cleaning, right after cleaning, or simultaneously, like both?
That's a good question. Jennifer, do you know? Are we doing it? What? How?
I believe the wipe test before
Okay, before cleaning.
and then after.
Okay.
Okay.
Don't ask me because I currently don't do wipe testing.
So Heather, for you guys, curious, are you running the ME panel in your, okay.
We send Ray our MEP.
You do, okay, so combination question here for the 2 of you. Have you ever had a case where you had a patient with an LP performed at your facility, and then they transfer that patient to the other facility with the CSF specimen and ask for an ME panel to be performed? In which case you now have almost a patient in transit with their own ME panel coming to you.
We have never sent the sample with the patient.
Okay, or just in general through courier process?
I mean, yes, I would send my CSF with a courier, and it may get there the same time that the patient gets to Ray.
Sure.
I know it's happened more than once, probably.
And how do you handle that then from a pre-analytical perspective of possibilities of contamination?
Yeah. As we set them up, we wipe the tubes down, the CSF tubes before we open them. But you're right on, Tyler, that's a concern.
Okay.
And from our perspective, it's, you usually get 4 tubes, right? So it's trying to make sure that if they order an ME panel, we have one that we've never touched. We haven't used it for cultures or, CSF cell count, stuff like that, so that by the time I send it to them, it's not already spiked.
Right. Okay, thank you.
And I would just comment. What we do is we just take a traditional swab and moisten it, and then we just go for the surfaces that we're interested in testing. And typically we do 3 or 4 surfaces per swab. So then when we do have a positive, we don't have as many to backtrack on. Because I think by some of our instruments, I think there's 8 sites that we sample, so that would be 2 swabs. And then run those 2, and then if one of them's positive, then go back and see if we can find the exact spot where the target nucleic acid was found.
I'm going to raise another issue. How many of you keep all of this testing entirely to be done within the laboratory, or do some of you have this type of instrumentation out in other sites that might be done by non-laboratory personnel? So some of you have those situations, and then that raises another wrinkle. How do you make sure that the staff that's doing that testing understands any of this? Again, this webinar I listened to recently was talking about laboratory having to supervise the point of care testing in all of these other facilities, and the fact that people don't have the same mentality. If something doesn't come in right on a control or something, they just keep repeating the test until it comes in instead of trying to actually figure out what's going on. So that's where critical thinking again comes in. It's so important we have that ability to know we need to use that. And so just my thoughts on this.
And I guess I just wanted to comment on kind of the scenario that Tyler brought up about negative in a gene expert assay, positive when they went with the full BioFire respiratory panel. I would probably say a half a dozen times a year, I get a call about just that event occurring, positive in one assay, negative in the other. And when Tyler mentioned, it was negative in the gene expert and positive in the BioFire, something from my past, the irony just knocked me over, because the BioFire assay, they use melt curve determinations. They don't have detection probes, and they do a nested PCR. They do an initial amplification, then they dilute that out, and then they do another amplification, and then they do that second amplification in triplicate, and then they look at all 3, and I think they say that 2 out of the 3 have to melt out specifically before it's called positives. And one of my mentors when I was a postdoc is now the chief scientific officer at Cepheid. And back there at the beginning of PCR, people were doing, it wasn't individual tubes, they were doing their initial PCR, and then they would take that and put it in, dilute it up, and do another PCR. And, there was a lot of concern about, carryover contamination and everything, and there were things developed called nesting boxes, and ARUP used to have a whole plethora of nested assays. And this gentleman, his name's Dr. David Persing, and when we were fellows, we were talking about nesting, and he looks at me and he says, "Ray, nesting's for losers." He said, if you can't build a efficient enough assay to go through with one set of primers and probes and go all the way through, you shouldn't be doing this. So again, the BioFire does use nesting, and we'll pick up maybe some more targets than other assays.
Any
Other comments or thoughts? All right, then thank you so much to our speakers, our presenters.